So I'm going to give you a bit of an overview of the Changing Futures programme, and then I'm going to hand over to Tara, who will introduce herself properly when I hand over. So yeah, if you want to go next slide. Cool. So Changing Futures is a 4-year funded initiative aimed at bringing together partners to work differently. Our goal is to see the whole person and the whole system, improving the experiences of the most vulnerable and disadvantaged in our communities. So the programme focuses on 3 levels. We've got the individual level, so stabilising and improving outcomes for adults experiencing multiple disadvantages. We've got service level, which is about enhancing integration and collaboration across local services with a whole person approach. And then we've got systems level, which is building strong multi-agency partnerships and using data to drive lasting systems change and inform future policies. So we're committed to testing innovative approaches and learning from our experiences to influence future government programmes and policies. Through this holistic approach, we aim to create sustainable change and provide better support for those who need it. Next slide. So why do we need it? First off, people with multiple disadvantages usually have very complex needs. These needs often overlap and are interconnected, but our systems aren't set up to address them all together. Services are often fragmented, meaning people have to navigate through multiple systems that don't talk to each other, creating frustrating gaps in support. Eligibility criteria can be very strict and narrow, which ends up excluding those who have more complicated needs. This can leave many without the help that they need. Stigma and discrimination within these systems can also deter people from seeking help. Negative attitudes and judgments create an unwelcoming environment. There's also a lot of bureaucracy and red tape involved, and that can be quite overwhelming. Complicated forms and processes make it hard for people to get the support that they need. There's also a lack of personalised support. Many systems don't provide tailored individualised help that people with multiple disadvantages really need. We've got resource limitations are another big issue. Insufficient funding, long waiting times means that people don't get the support they need in a timely manner. Access to support can be inconsistent, leading to unequal support depending on where you live or which system you're dealing with. And then cultural insensitivity can make people from diverse backgrounds feel alienated and misunderstood, further complicating their ability to get help. And lastly, there's limited advocacy. So without proper support to navigate these complex systems, individuals are often left to struggle on their own. It's not all doom and gloom. I'm going to tell you how we're hoping to address these issues on the next slide. So these are the key work streams of Changing Futures, just some of them actually. So firstly, we're testing new frontline services and delivery models. So we're experimenting with new ways of working. This includes our specialist team. It includes our place-based approach at Churchill Gardens and our Blue Light project, which works with change-resistant drinkers. We have our system improvement projects. So through our work, we've identified several system improvement projects. These include amplifying trauma-informed practice, our Artemis project, which aims to improve outcomes for prisoners on the day of release, and we're also developing support projects for young adults experiencing homelessness. We've got our system capacity building work. This focuses on this includes things like workforce development programs, embedding co-production, supporting others to do the same. And our aim here is to build a system that can respond more effectively to complex social needs. And then we've got our longer term change and legacy. So we're using all our learnings to build an evidence-led case for lasting systems change. This involves identifying recommendations and demands for longer term programs. Now I'm going to hand over to Tarah to give you a bit more information on our specialist team.
Hi all. So as Christy had said, so I'm the practice manager for the specialist team. We came into operation in January 2022, so I've been with the team since the beginning. And our team are basically made up of practitioners from a range of different backgrounds. So most of our practitioners are senior practitioner, specialist practitioners. Some are social workers or have had extensive experience working in youth work, also mental health services and homelessness support. And then we also have assistant practitioners in our team. And that was actually a new role that we created during our recruitment process. We identified a barrier that we just weren't receiving applicants from a global majority, and potentially that's a result of societal barriers. But what we're seeing is that we have these individuals that possess that real genuine passion for supporting those who experience multiple disadvantage, and those real intrinsic engagement skills, but not necessarily being able to meet the formal criteria. So to broaden the opportunity, what we did was we provided a package of training within post and created the role of assistant practitioner. Also within our role, we have our peer mentors. So these are young people, similar ages to the people that we work with, but who have had lived experience. And the peer mentor element supported the development of the bid actually from when we began. And it was identified that it was really beneficial for young people to work with others who similar ages, but also had similar experiences. And providing that kind of almost a light at the end of the tunnel kind of perspective. So we have our peer mentors and coordinator within our service, and then also psychotherapists. So we're able to provide that clinical input and really flexible with it. So whether a short-term clinical input or long-term clinical input, we have that capacity to have our psychotherapists either work alongside our peer mentors and practitioners with other young people, or perhaps just do short-term work with people who may not meet all of our criteria. And the young people we work with are all Westminster residents, aged 18 to 25. So it was really about trying to take the opportunity of where you had children transitioning into adulthood and maybe not being able to meet the threshold of those adult services. So us working with 18 to 25-year-olds really provides that opportunity where it's a really crucial time in their lives, particularly for those who have experienced the type of disadvantages that we work with. And for us, everyone we work with is experiencing 2 or more with the multiple disadvantages, which we identify as being ill mental health, risk of homelessness, substance misuse, involvement with the criminal justice system, and then experience of domestic violence. And what we do is we take a real trauma-informed approach at working with these people. So everyone within our service has had extensive training in trauma-based interventions, as well as compassionate mind training, which I'll speak a little bit more about later. And it's really all about supporting these young people to really focus and kind of understand to prevent some of the emotional distress that they've experienced that's been related to their disadvantages. And we do that using clinical measures. So we assess like depression and anxiety at point of referral, and then we use that throughout their time working with us to look at progress. And then we create care plans in partnership with these young people where we're using very specific, measurable, achievable and relevant time-based goals, which we co-produce with them. So what that care plan would look like. So we do that within 6 weeks of working with our young people, and we actually use solution-focused brief therapy. So that's a psychological intervention where it really focuses at supporting an individual to identify what their goals are by looking at their strengths. So what you do is through a line of questioning, you get the person to really look at exceptions to patterns of where they've had challenging behaviours. You look at where there's been exceptions and you're encouraging them, encouraging them to look at their resources and their strengths rather than focusing on the problem. And with that, you really support the person to identify what their preferred future would look like and look at what those steps would be to achieving that. So with each goal, we're identifying the steps, and we're having that young person work with us and say who they think takes responsibility for each step. So whether it's something that they're doing alone, they're doing with us, it's a peer mentor, what have you, but it's all about having that co-produced plan and helping them feel in charge of their care and what their goals are. Sorry, excuse me. And this is done, so as I said, we do it initially within the first 6 weeks, and then we review that every 3 months. So using the care plan as the kind of foundation of, okay, this is the goals that we have for the young person, and this is what they've identified, what they want support with. What we really then focus on is trying to make sure that we are pushing a real relationship-based practice. All of our practitioners, peer mentors, we focus on building a really strong and trusting relationship with our young people, because we understand that it's probably one of the most influencing factors when it comes to how effective any therapeutic relationship intervention is, and that's the relationship between the service user and the facilitator. So we work quite intensively with our young people. So we have quite small caseloads to provide us a space to do that, seeing people up to 3 times a week if necessary. And at the point of when we started, being able to work with people for up to 12 months. Some people we did work with longer, but it was really about having that space to build that consistency and time with young people, so that we can really provide them with those skills that they need to feel empowered to make changes and manage the emotional challenges, but also to navigate the adult world. And when I say navigate the adult world, it's a lot of advocacy work that we're doing, support around services, whether it's housing or benefits, life skills and budgeting. And those aspects are really heavily facilitated by our peer mentors who have that kind of extra scope to support people if it's to go each morning to college because they have anxieties about leaving the home, or accompanying them to a sexual health clinic appointment. One of the main things that we really focus on is being needs-led and having our young people feel in charge of the support and care that they desire. So we're really flexible in that working. Sorry, my voice is going. Really flexible in the way in which we work. So we work across community, meeting young people, whether it's at their home, in the office, in a cafe. Again, just finding what's convenient and comfortable for them. We offer groups. At the moment, we're currently doing a women's group, which provides a safe space for young women to speak about problems, very much so focused towards their age group. So I think some of the topics have been things such as social media, body image, healthy relationships and gaining tools, but also being able to increase their social inclusion and meet other people who have similar experience to themselves. We'll be doing the men's group shortly after that one. And we've also had groups in the past facilitated by our psychotherapist, where we had young people having the opportunity to gain really practical skills of how to manage distress. So really trying to broaden out not just the one-to-one work, but also supporting young people to feel more socially included. Then we do offer support to other services and organisations, and much of that looks like very trauma-based practice, helping organisations to understand the impacts of adverse childhood experiences, what that looks like, and maybe recommend interventions for use for people that they may encounter who have similar problems. And it is all about taking a real trauma-informed approach to addressing some of the challenges that people who experience multiple disadvantage have. And compassion is at the core of our approach, and that's governed by our practice model, which we call the Changing Futures HEART model. So HEART's an acronym for Holistic, Empathetic Assessment and Recovery from Trauma. And it's an approach that incorporates a range of theories and practices, and it facilitates and promotes a deeper understanding of the underlying causes of complex behaviours such as substance misuse and criminal involvement. It's really informed by the notion that challenging presenting behaviours or emotional distress are often developed as a form of psychological defence or a coping mechanism, as you will, as a result of historical exposure to trauma. And is really deep rooted in that exposure to adverse childhood experiences. And we know with adverse childhood experiences comes complex trauma, and this is often experienced through experiences of abuse or neglect, poverty, parental mental health. And we know that they have lasting effects on health and well-being of people. And often in that state of vulnerability, this is where sometimes unhelpful coping strategies do occur, such as using substance misuse for escapism, or having challenges with relationships due to difficulties with trust, because being grown up in an environment where maybe you wasn't able to trust adults, or adults haven't always been there to keep you safe, can, we know, reflect in how we relate to people later on. And what we find in our cohort, it's an average number of 7 or more adverse childhood experiences, which is quite average for the people that we work with, over 70% of all the people that we work with have had experience with children and family services. So what we hear is that, you know, they've had a lot of experience of having lots of professionals involved, and this is why it's really important for us that we really prioritize building that secure, trusting therapeutic relationship. Them having just that one allocated practitioner that's holding all of the, you know, helping them with all of their challenges, and stopping them from having to repeat their story again and again, which many of them have spoken about finding difficult. And in doing this, we have 4 main interventions that we use alongside the practical support, but these are the interventions that we're using to really support in helping young people really address their experiences of trauma and then build an understanding and skills to manage that. And what I'm going to do is I'm going to talk about a young person that we worked with previously, just so I can highlight exactly how the interventions were used with her, and just give you a bit better of an idea of just how it's used in practice. So the young person we speak about is someone called Jo, and she was referred to us by community mental health team. And she had significant involvement with children and family services throughout her life. Her mum had significant mental health problems and alcohol misuse, and Jo actually went into care at the age of 7. And at the point of referral, there was a lot of concerns about Jo's, particularly her safety. So she would quickly get into relationships with men that she didn't know very well and had been assaulted multiple times by these men. She had, in the 6 months leading up to working with us, she had had 2 psychiatric admissions and was frequently self-harming. She really struggled with budgeting and with her money, so often would steal, and really kind of struggled with understanding her kind of rights and responsibility as a tenant. And she had had quite a lot of warning letters from her housing provider and was at risk of losing her tenancy. So when we started working with her, was very much, as I explained, did the care plan with her, and her goals were really, she wanted to stop self-harming. She wanted to stay out of hospital, out of psychiatric hospital. And she spoke about wanting to manage her feelings of loneliness in a more positive way. So what we did with Jo and what we do with most of our young people is started by introducing her to the idea of compassion. So I know people speak about compassion a lot, but using it from the compassion-focused therapy approach, when we're talking about compassion, we're talking about the definition as it being a sensitivity to and an understanding of the suffering of self and others and its causes, with a commitment to try to relieve and prevent it. So it's really about being able to engage with the distress and suffering that one person has, but then being committed to saying, I want things to be different. And it's a real empowerment approach because it encourages that understanding that it's not your fault that you may have these feelings, but it is your responsibility to make positive changes, and positive changes can occur. And the reason that we focus a lot on compassion is because it's needed by the human brain. So if we think about the primitive brain that we have, it's wired to survival. And to survive, we need to be aware of threats, and to be aware of threats, we need to avoid harm. So our harm avoidance is what triggers emotions such as anger, fear, anxiety, and this was also then helps us to do that fight or flight response. So these are our basic emotions, and these are basic wiring within our brains. But as things have changed, as our brains have developed, rather than becoming like anxious and fearful from like a bear walking into a camp, we're experiencing the similar emotions because you realize a friend has gone out with a mutual friend and not invited you to. You know, our brains are just as wonderful as they are. Because of that hard wiring to detect threat, we automatically direct our thoughts towards negative. And that can be really tricky, particularly if you've also experienced some of the adverse childhood experiences that the people that we work with and Jo has experienced, where your brain is wiring and directing itself towards negative. This is where people end up in really unhelpful mental loops, and you get in these quite negative self-talk where there's a lot of self-blame and guilt that occur. And by taking a compassionate view, what we're trying to do with young people is help them build awareness of these thoughts and then reduce that blame. So using compassionate mind training, this provides them the skills to do that. So compassionate mind training is a subclinical intervention from compassion-focused therapy, and it's all about teaching someone that the psychological distress is a result of that internalized shame and self-criticism. And what it does, it support individuals to really understand, as we said, the evolutionary reasoning of why they may have these negative thoughts. So it's not their fault, but then cultivating skills so they can manage it. So what we did with Jo is really teach her about why her brain, as she would say, well, I'm always focused on the negative, but why it does that. So real psychoeducation to empower her to make sense of why she may have the challenges with her thoughts that she does. And then having an understanding of her emotional systems. So within compassionate mind training, we see particularly emotional distress as a result of an imbalance within your emotional systems. And very much so having an underdeveloped soothe system. So the area of us which enables us to relax, to feel peace, to settle. And using tools like mindfulness and visualization, it supports people to be able to regulate. So I know people hear about mindfulness a lot and think, oh, it's just about feeling relaxed. But what it really is about is helping someone to learn skills about how to direct their thoughts. So it's all about how to focus intensely on the here and now, in opposed to some of that negative talk. And we use soothing rhythm breathing and guided imagery in order to support people to gain that skills. And for Jo, that was really the foundation steps for her, particularly as someone who did often use self-harm when her thoughts became really distressed. She found it really helpful to have a tool that she could use to know, where she could focus on her thoughts and redirect, knowing how to, okay, like I'm starting to feel distressed, knowing how to feel it in her body and how to use an active tool in order to move away from them. And then building that compassionate, kinder view of herself instead of that real self-critical mode, which she often get into. Then we also did a trauma-informed mapping exercise, which we call a time. So Jo would describe having lots of challenges in her life, a lot of which that she would blame herself about. And, a narrative with her very often was like, I make bad decisions, which is why things happen to me. And in doing an intervention like this, it really provided her an opportunity to explore her past experiences and understand how they influence her present day challenges. So though Jo had children, family throughout her life, and she had told her story to multiple professionals, she didn't really have had the opportunity to address the traumas of her past in the same way. So with this exercise, what we do is we construct a genogram, which is like a pictorial family tree, and it enables the person to really understand family dynamics and look at intergenerational patterns. For Jo, it was really helpful because it enabled her to see some of the patterns between her mum's relationship with her own parents, her grandparents, and why her mum herself ended up having some of the emotional challenges that she had. And then what we do is construct a timeline, and it goes from birth all the way to present day, in which Jo was able to identify significant events that happened and events of her choice. And what it does is it really helps to develop an awareness of the frequency and the severity of exposures to adverse childhood experiences for us. So it provides that assessment tool, but for her, it enables her to really externalize the experiences that she'd had. And all of this intervention always ended with reflective conversation, where we really focus on the strengths and how she's managed those experiences, and really kind of facilitating to accept and understand that none of the experiences are her blame, and that she shouldn't feel shame about it, but that these are all the consequences of things that have just happened, and helping her understand that she's able to make changes and things can be different. And she always said she found that really powerful, because whereby she had always held her stories within her body, being able to see it in front and really externalize it and really make the problem something outside of herself was really powerful for her. And it's intervention that we try and do with all of our young people, and sometimes with caregivers if they are involved. And another intervention which we try and do with caregivers also is our attachment informed games. So it's actually an adaptation of TheraPlay, which is a play-based intervention that was originally created for foster and adoptive parents and then their foster children or adopted children. And it is based on Bowlby's theory of attachment. So we know that the secure bond that a caregiver has with a child is an evolutionary requirement for survival, but it's also essential for psychological well-being and has a massive effect on how we build relationships with others and how we build relationships with ourselves. And where people may have had experiences which mean that they have insecure attachments, often, due to some of the adverse childhood experiences that we spoke about early, we know that can lead to people having really disorganized and really avoidant type of attachment styles and really affecting how they see their sense of self. So within attachment informed games intervention, what we do is we use playful activity and touch and games in order to provide the young person an opportunity to feel secure attachment. And that's either with Joe's case, I took the place of the caregiver because her mother wasn't involved. But if the caregiver is around and we're able to facilitate that, we facilitate that with the caregiver and the young person. And it is all about providing that safe space where they can feel challenge and nurture in a safe environment to build up their self-esteem. So as I said, it's a lot of play-based just games and activity, but also involves a lot of touch, like things like hand massages and safe touch. And I think Jo, where she had so many experiences of feeling physically violated, yet also really needing and seeking physical contact, safe physical contact, being able to have sessions where she could receive that and understand what safe touch felt like and understand what safe attachment and secure attachment felt like was really powerful for her, because it helped her to build that internal sense of self and in a positive way, understanding that she deserves to feel safe, that she deserves nurture, and has been a really powerful intervention for her and for many of our young people, especially the ones where we've been able to use it with their caregiver too. So what are some of the outcomes for Jo? So as much as doing these interventions with her, also introduced her to one of the peer mentors while we were working with her, and they really supported her with her budgeting. So really helped her to look at how she managed her income, and then also understand what other available support mechanisms there were outside. So things like Thames Water Help and other benefits, and helped her to apply for that so that she could utilize her income more efficiently. She attended the women's group and was able to really connect with other young people with similar experiences, and she began to visit her mum in a more boundaried way. Prior, her contact with her mum was really sporadic and very difficult, and very much so through doing particularly the attachment informed game, she was able to start what she describes having a healthier relationship with her mum, where there wasn't that anger, and where she was able to just enjoy her in ways that she said that she hadn't. One of the significant things for Jo, which she was really proud of, was the fact that she stopped self-harming. So she had previously self-harmed at least once a week, but within about 7 months of us working together, she had reduced that to not any self-harming behaviors at all. And that was her using those compassionate mind tools when she did feel distressed, being able to be aware of when she was becoming distressed within her body and having a tool to use rather than self-harming. There was no involvement with any of the mental health teams. And she described a significant improvement in her mood, which was also demonstrated when we did the clinical measures, her scores going from, it was very severe to moderate, which she was really, really proud of. She had ended her relationship with her abusive boyfriend and was very much so focusing on herself. And she really spoke about just how important it was for her to have a practitioner that she could trust and feel empowered, because for her, having that sense of being able to manage, when we started, she felt, she describes feeling hopeless and not feeling that things would change, but having the skills taught to her and equipping her with what she needs to move forward had been really beneficial for her. And her words, she described our intervention. So she said that each session was always coming from a place of love and care. And really us just trying to demonstrate compassion through all interaction that we have. And spoke about, I really value myself, understanding why I was hurting myself, and I never want to do that again. And I think, again, that's in that psychoeducation of really understanding why she had the challenges with the behaviours that she did, and giving her the tools to be able to work through that. And I think the beauty in the team that we have is the fact that we can really, like we sometimes joke and say, kind of throw the kitchen sink at people, whereby we're giving them the therapeutic support, but also those practical needs as well to help them navigate the adult world. And it's all about them feeling empowered, feeling like they can take charge, feeling like that they can make changes for their future, and feel that there's a service that's responding to their need by enabling them to work in co-production, in identifying their goals and really work towards that. And it's been, we've had a lot of positive experience with them. We just hope that with all of that people are able to see that using a tool where you're equipping young people therapeutically, but also providing that practical support really enables them to make the differences that they want for their future. Yeah. Is there any questions?
People, please do just put up your hand, or if you prefer to post in the chat, write in the chat if you have any questions for Christy and Tara. Thank you so much both for talking about the work you're doing. I find I mean, I know I've seen some of it before, but I just think it's really moving to see the progress that people are able to make. And and also just actually that picture of Joe's timeline, actually, just the amount of difficult things that she'd gone through. It's just really eye-opening to understand like why some of like young people are behaving the way they are, because they've just been through so much. It's just hearing that is really just informative and helpful in terms of how we respond to people. We're quite often running focus groups and engagement sessions, and sometimes people don't behave the way you expect them to behave, and you don't really know all of this stuff going on for them behind the scenes. I've got a question here from Adam Taylor. He says, does the work of the specialist team tell us anything about the way we might need to change the way we deliver other services?
I think one of the biggest things I think about is, I guess, the entry to services. The big challenge that we have with the cohort that we work with is that they don't meet the criteria for a lot of the adult services. So we're working, as we said, like 70% of the young people we work with have had children and adult services involved. It means that they have experienced complex trauma. So and we understand the psychological and the physical health concerns that happen for people with that experience. However, you have adult social care services that really only are able to focus on the older adult community, and there just isn't services available for young people. And even when they do come into contact with those services, we're talking about people who have had lots of professionals involved, may have difficulties with trust, and may struggle with engagement. And one of the things that we do quite differently is we're quite flexible in, we'll get a referral, and sometimes it may take weeks before we see that young person because they don't answer the first call, and then you text them and then they'll text you back and then they don't text back. And we provide that space, understanding that, we're a stranger and maybe you've not always had the help that you needed and this feels strange. And I think being able to, and that's that trauma-informed approach. That's understanding them when you have people who have had multiple disadvantages, the way in which that they respond to services may not be, I guess, what you expect, like run towards it, because they've just not had that experience and they're not equipped for that. So really being able at point of entry to think about how do we lower the points of entry and understand that we do have young adults who maybe they don't have the obvious physical health concerns that you see in the older population, but the psychological difficulties that they have, we know really impact their well-being like down the line. So how we change that, and then how we create some flexibility so that when people do struggle to engage, we create space for them to access services, because I think that's a difficulty that a lot of our young people describe experiencing.
Thanks. There's another question from Jeff Perkins. How do people engage in this system? They'll be very troubled and won't think to search for your facility. How do they know about you? Yeah.
A lot of that has been us having to advertise ourselves, I think, to be honest with you. So at the beginning, and we still do, have gone round to services, all services, so from healthcare services to homelessness services, and basically just advertise our existence. That's really, we do have a website, but again, I guess it is one of those things that unless somebody is at a stage where they know that they need help, it might be difficult. But so far we've actually just had to do our own promotion, unfortunately.
And most of our referrals come from either children's services or NHS services. And I think that really speaks to the gap in service provision between 18 and 25, because they're searching for us. And we have we do have a small portion of referrals that come from self-referrals, and that's mostly through word of mouth. One young person has told another young person that they've received the support and it's worked for them.
One other question I had on the back of Adam's question was just clearly, a lot of the young people have had quite a lot of sort of adverse experiences before they get to you. And do you think there are things that maybe they might have needed to access at that time, but the opportunity wasn't there? So is that something we need to be thinking about in the service we're running? Just thinking about Jo, like it looked like she'd had a lot of friends who had, I'm not quite sure if it looked like they'd maybe taken their own lives. Did she get the support she needed when she was 14? Or are there more things that maybe we need to be putting in place?
I think one of the things she spoke about was it was having kind of different professionals, which was really difficult. That's why we really try and focus on having that kind of specialist practitioner who is able to support that young person, so that we don't have to refer out to things. So what was helpful with Jo is the fact that I could go to she's one of my young people. I could go to her house and we could do an application for her housing tenancy, but then also while she's on the phone getting really anxious, provide her with the therapeutic tools to manage that at the same time. That holistic wraparound care from one person where she could build that relationship was what was really needed for her. And she spoke about the fact that she didn't always have that opportunity. There wasn't, she'd be referred to CAMS for psychological support, but then they couldn't help her with making friends, or meeting other young people, or advise her on how to build up interest. So I think it's that which makes us really different. It's the fact that we really have focused on making sure we have a team of people who are really experienced and have the skills in order to manage all of the challenges that people who've faced multiple disadvantages have. So work therapeutically with them, but understand what are the kind of lifestyle things that they're missing. There isn't a book that teaches these young people what to do when they become adults. Like no one teaches them what council tax is, or like how to apply for housing, but like no one does that. So being able to have that one practitioner that does it, I think has made the massive difference, particularly from the feedback that we've got from our young people.
That's fantastic. Thank you so much, Christy and Tarah. And people, if you've got any more questions for Christy and Tara, specialist team is still here until March 2025. Please, do come and reach out, and we'd love to hear from you. Thanks so much. Take care, everyone. And I'm going to close up. Bye bye.